Good morning. My name is Joel Marx, and I am speaking to you from Cleveland, Ohio. I am chairman of Medical Service Company, and I'm so honored to be able to greet you this morning for what I am sure will be an outstanding day of education and learning. Our team at Medical Service Company has been working for months to bring you the right mix of speakers and CEUs necessary to continue your service to patients and the profession. I salute you all for investing in not only your future, being a healthcare hero during this particularly challenging time. My parents, Gene and Merle Marx, started Medical Service Company in 1950, and I have spent my career expanding our services and using technology to improve patient care. My mom, Jean, was a great ambassador for our organization and loves to spend the day in person with so many of you at our annual seminar. She passed away several days before the program in 2004, and it was renamed in her memory. We are so pleased to be able to continue to offer this program virtually through the generous support of our sponsors and this year with help from service providers around the country. Please thank them for their support. Medical Service Company now serves patients in 11 states and is continuing to develop services to provide respiratory care, treat sleep apnea, and provide medical equipment services throughout the region. Our outstanding healthcare team has transitioned to new ways to connect during the pandemic, and we are proud of this outstanding group of men and women. We continue to grow by serving our team, serving our patients, and partnering with hospital systems, healthcare providers, and insurance companies. I hope you enjoy the program today. Though we are distanced and safe, we are all together today. Thanks for all you do to make this a better world for everyone.
Thanks, Dad. Hello and welcome. My name is Josh Marks, and I'm the Vice President of Business Development for Medical Service Company. We have an action-packed day lined up for you with 10 speakers from distinguished universities, health systems, and supporting organizations with expertise in sleep and respiratory disease management. While this is our 20th year hosting our education forum, we have many first-timers from across the nation. So let me give you a quick lay of the land for today's program. This morning, we'll have 4 sessions for all of you to attend, the 4th being the keynote address. Then, after a 30-minute break, there will be concurrent sessions running the remainder of the day, one for the sleep discipline and one for the respiratory discipline. Throughout each session, you can submit questions under the Engage tab, just above the presentation screen. Speakers will address questions following their presentations as time allows. All sessions have been approved by the AARC, and all morning and sleep sessions approved by the BRPT for continuing education credits. Make sure you fill out the evaluation form at the conclusion of each session. At the end of the day, you'll be able to download your certificate from within the conference site. Click on the account link in the left-hand vertical navigation, scroll to the bottom of the screen, and under Attendance Certificate, click Request New Certificate to download a certificate detailing all the CEUs you have earned. Before we kick things off, I'd like to thank all of our speakers, sponsors, and DME partners. Sponsors, thank you for your support of this event, but also for what you've done this year, working tirelessly to ensure critical respiratory equipment and supplies have been available when patients needed them most. DME partners, it's inspiring to see so many of us banding together for the benefit of patients. All of today's sessions are directly related to managing sleep and respiratory diseases. Because of the valuable information being shared by our speakers, the entire country will be better equipped to care for those sleep and respiratory patients that we encounter and care for every day. For the past 20 years, this educational forum has been dedicated to sharing knowledge and empowering our allied health professionals with a full day of continuing education. It was our goal for the 20th anniversary to be able to extend our reach far and wide, and because of all of you, we have been able to fulfill this vision. One more thing. Before each session, you're going to learn a little bit more about MSC and hear from a few of our team members. If you'd like to learn more about anything you hear and how we can support you and your patients, visit medicalserviceco.com. Now, let the forum begin.
Good morning and welcome. Our first lecture is a diagnoses, clinical implications, and treatment options associated with OSA being presented by Dr. Srinivasan Devanathan. Dr. Devanathan is currently the Medical Director of Adult Sleep Medicine at Parkview Hospital in Fort Wayne, Indiana. He was honored with a 5-Star Excellence Award in Sleep Medicine in 2014, 15, and 16 for his success in expanding the sleep medicine model. Along with over 15 years' experience and several certifications in sleep and pulmonary medicine, Dr. Devanathan is also an experienced internal medicine physician in addition to pulmonary and critical care. He currently holds professional affiliations with the American College of Chest Physicians, the American Academy of Sleep Medicine, and the Indiana University School of Medicine, Fort Wayne. We are happy to welcome Dr. Devanathan as a new speaker to our event and are grateful for his willingness to participate. Upon completion of his lecture, Dr. Devanathan will take questions from you. To submit questions during his lecture, click the Engage tab above the presentation screen.
Very happy to be invited to talk about obstructive sleep apnea, primarily as my area of focus today. And I'd like to indicate, first of all, there are no financial disclosures. The slides and material that I use is primarily for the American Academy of Sleep Medicine for public lectures. I did add a few additional slides. They've been incorporated. They're not part of the original ASM slide set. So to start with, when we talk about obstructive sleep apnea, there's often a little bit of a confusion in the definition, so to kind of simplify those definitions, I think it's worthwhile going through what apnea, hypopnea, and RERA really mean in the sleep world. So these are abnormalities in breathing. Apnea is where there's a more than a 90% drop in airflow excursion from the baseline, which lasts more than 10 seconds. Hypopnea is more than 30% drop in airflow from baseline. That should also last 10 seconds, but the rules in the scoring manual often include the association of 3% oxygen desaturation or arousal. So when we look at the 3% oxygen desaturation arousal, this is more applicable, especially if we are doing sleep studies in the sleep lab. If we are doing any testing in the home setting, then obviously the oxygen desaturation is what we look for, as we do not have EEG recordings on a standard home setting sleep study that we do in the home setting. And then we have something called the respiratory effort-related arousals, where again, the length of the event has to be more than 10 seconds, and there's an increased respiratory effort or flattening of the inspiratory waveform leads to arousal. And this does not meet a criteria for apnea or hypopnea. So here are some examples of an obstructive apnea, as in where you can see that there is a lack of airflow, as the nasal pressure transducer is with a thermal sensor, and accompanying that lack of airflow, there is a effort that's generated here that clearly indicates that as the airway is closed upwards, there is an increased effort from the body to help to overcome the closed airways issues that may then ensue, and therefore to restore to normalcy in the breathing. So we have a similar situation where there is a shallow breath going on that is called the hypopnea, where it is not completely flat like the apnea, but this also has to be 10 seconds long. And accompanying the shallow breath is a continued respiratory effort that is measured. And because there is a continued effort, we call it as obstructive hypopnea, otherwise the shallow breath. And the third group is the respiratory effort-related arousals, where there is not a complete drop in the flow signal to a point of apnea or to a point of even a shallow breath, but there is a reduction in the airflow, which when accompanied by continued respiratory effort, and arousals occur at the end of that respiratory effort, where there's a change in EEG, and these also typically are about 10 seconds long. So these are the standard distributions of respiratory events that occur in a sleep study, whether you observe them in a home test, both in a home test and a lab test, and this is specifically seen in a lab test or a sleep lab study where you include EEG to mark the arousals. So once we identify irregularities in breathing, we have to measure the sleep apnea frequency, and those measurements are indicated by common terminology, which are indices. So you have something called the apnea-hypopnea index, which is a common terminology all sleep physicians use, where it is a calculation of the number of apneas and hypapneas per hour of sleep. And then we have the respiratory disturbance index, which includes the apneas, the hypapneas, and the respiratory effort related arousals. So this is the difference. Of course, the language sometimes goes between choosing what we call as AHI and RDI in different sleep centers. But commonly, when we include RDI, we include additional respiratory effort related arousals. And then we have what we call as the surrogate for the AHI, which is used in the home sleep studies. That's called the respiratory event index, where we often monitor the number of respiratory events per hour during a monitoring time on a home sleep apnea testing, where we exclude any data that may not be adequately presenting itself to provide meaningful sense. So exclude all that data and take what is measured from the total recorded time, and excluding data we included as monitoring time. We include the abnormalities in the numerator divided by the monitoring time and arrive at what we call as a respiratory effort, respiratory event index. So the standard definition for sleep apnea would be that we have more than 5 obstructive respiratory events. So as I mentioned earlier, there is not an inclusion of the word of apneas alone. There are more than 5 obstructive respiratory events, which include both apneas and hypapneas. And oftentimes there is additional symptoms. So snoring, witnessed apneas, fatigue, somnolence, a mood or cognitive disorder, hypertension, type 2 diabetes, stroke, cardiac disease. Most patients could present with a combination of these symptoms, or may have isolated symptoms, such as snoring, or may come in with witnessed apneas. And if we look at that, the definition there often talks about either having a 5 or more with a associated symptom and or medical disorder, or it has to be clearly more than 15 obstructive respiratory events per hour on an independent basis. This is a very important slide. This is the anatomical appearance of the upper airway sliced down. And I think the points that we have to obviously remember here, the tip of the nose, the posterior choanae, the epiglottis, the mandible, the maxilla, the hard palate, the soft palate of the epiglottis here, the tongue, the hyoid bone. Now, what's important here to note is the space that is here between the posterior choana and the epiglottis. This is our free falling space, if we may say. And why is it a free falling space? Because the rigid hyoid bone in mammals or animals is freed in human beings, obviously, and that freedom allows the muscles to move, the genioglossus muscle and other muscles to move. But at the expense of that, obviously, then there is the ability to phonate, which is a good thing, but at the expense of it, there is also that increased vulnerability or collapsibility of the airway. And oftentimes, it's this vulnerability that is often used in many scenarios to apply different methods of therapy, whether it be positive pressure therapy, whether it be a dental appliance to move the jaw forward, whether it could be a newer modality of therapy, like a nerve stimulator to move the tongue forward, etc. So while this potential space is actually, as a free falling space, is good to help us speak and phonate, etc., it also is a vulnerable space that can predispose to an increased collapsibility of the airway. So when we are awake, there is this potential space, which, as you can see here, during sleep tends to narrow down and close off. And that's why it is very important anatomical landmark when we look at the 2 slides and understanding the pathophysiology of apnea. Medications that individuals take to help them sleep, once sleep becomes a powerful relaxant, theoretically, this is what happens to the airway. So a lot of times people end up even on what was considered to be not potentially respiratory depressants, but just the concept of sleep being a relaxant can increase this closure of the airway capability. So there are, obviously, going back as we went to the previous slide, and we're talking about the different segments here. So we talk about the area behind the pharynx, which is behind the nose or the nasopharynx, posterior to the soft palate. So that would be this area posterior to the soft palate. And then we're talking about the pharynx, which is posterior to the tongue. So that would be exactly right over here. And then we're talking about the retroepiglottic space, or the larynx or the hypopharynx, which is posterior to the epiglottis. So right about there. So these are important areas of pharyngeal segments where the obstruction can occur. And when this obstruction occurs, then obviously we have to identify whether these are multiple layers of obstruction or there's a single point of obstruction that can lead to more problems. So the pharyngeal muscle activity, as we can see, it's influenced by the palatal muscles and the genioglossus, which is the tongue muscle, and the normal airflow in a normal subject. When they're awake, the airflow is maintained, but as they tend to fall asleep, there is a easier tendency, it may not be apparent to the eye, but there is a greater tendency for the airway to relax. But in an OSA patient or obstructive sleep apnea patient, while their wakefulness drive, the dilator muscles have to keep really more active, remain more active. And as soon as they get into the process of falling asleep, whether it be the palatal dilator muscles or the genioglass muscle, you can see the airflow drops as soon as they, even in the wakeful state, they are relatively low. And as soon as they fall asleep, it just plummets down and they end up almost becoming apneic. So that's why it's important to evaluate and see examination of these individuals is also important to looking at the crowded airspaces, etc., because these individuals who are more prone to sleep apnea have a greater tendency for collapsibility of the airway. What happens in the process of wakefulness to falling asleep, the combination of wakefulness that keeps our muscle patency sort of drops at sleep onset, the neuromuscular compensation drops. The anatomically narrow airway with the loss of the neuromuscular compensation leads to the collapsibility. That collapsibility then translates into the definition of having an apnea. Apnea thereby induces hypoxia and hypercapnia, lower oxygen, higher CO2 levels, which then increases your respiratory drive, ventilatory effort, which then results in the arousal, a gasp, and a wake up, which can be multiple mechanisms: coughing, sneezing, cough, and waking up, sometimes feeling choking, and a big gasp, etc. Those arousal mechanisms for sleep induce the restoration of the pharyngeal muscle activity. The airway opens, there's hyperventilation, and the sequence keeps going back and forth. So it is something that we have to be aware of. So what are the consequences of sleep apnea? We get obstructive events. They in turn result in intermittent hypoxia, hypercarbia, cortical arousals, adrenergic pulses. These are what translate into various events, and or in the form of recognizing increases in blood pressure, can result in mood disturbances, can result in memory loss issues, a variety of things that can often result as a combination of the above mentioned chemical abnormalities and adrenergic pulses, and also result in thereby daytime symptoms and cardiovascular outcomes. So this is a busy slide. Then obviously it has the consequences of cycles of sleep apnea and recovery. As you can see on the top, there is the reflection of low oxygen and increased carbon dioxide, which contributes to a variety of changes. There's decreased oxygen delivery leading to organ dysfunction, oxidative stress and inflammation as a result of the repetitive cycle of apnea and recovery may lead to endothelial dysfunction, which has been well studied. The low oxygen hypercapnia, increased CO2, the low oxygen hypoxia, induce pulmonary vasoconstriction and increase the right ventricular afterload. And there is also a degree of sympathetic activation, which thereby increases blood pressure, arrhythmias. Now, on top of it, the arousals that occur as a result of the recovery from an apneic episode as a mechanism induce sympathetic activation and thereby contribute to blood pressure, arrhythmias. There is also a parasympathetic withdrawal, thereby increasing the heart rate. Now, the process of holding your breath, changing in the intrapleural pressure, the negative pleural pressure, increases the transmural pressure of the cardiac chambers in the aorta, increase the pulmonary capillary hydrostatic pressure. That means there is leaky capillaries. The consequences of this are that there is more afterload, arrhythmias, as well as increased lung water or a tendency to have negative pressure, pulmonary edema in a lot of cases. So the next slide obviously talks about the mortality. And as you can see on the graphs here with the red bars, and as they are plotted down, we can see that when the apnea-hypopnea index increases to greater than 30, the mortality rate also increases. And this is a graph that shows the survival probability that has been published, data that is about almost 10 years ago, but still holds very valid for how important, relevant obstructive sleep apnea is. There have been two studies, the Wisconsin cohort study and the study from Busselton, Australia, which have followed patients for about 18 and 14 years respectively, and again indicate that the mortality rate does tend to increase when the apnea-hypopnea index obviously increases over 30, as we can see in the Wisconsin cohort, and the Australian study when the RDI or AHI was included to be greater than 15, which are characterized it as moderate obstructive sleep apnea. There is also the non-fatal cardiovascular events. We can see that the non-fatal cardiovascular events probably increase as when there is not any treatment in the severe OSA group, which is the sort of a pinkish red graph that keeps going up. The line, the plotted line that goes up is the one that talks about the severe obstructive sleep apnea group, where the non-fatal cardiovascular events increase as compared to controls. And those who have mild obstructive sleep apnea, snorers, or those who have actually been treated for sleep apnea with CPAP. The sleep health art study again showed the relative risk and odds ratio of having coronary artery disease, heart failure, strokes. As we can see, when the RDI or the AHI increases, there is a proportionate increase in the risk for coronary artery disease, chronic heart failure, and stroke, as can be evidenced on the different RDI quartiles that have been marked out here. So this is another important study that has always thrown so much light in sleep apnea management overall, that has actually provided so much education also in the relevance and importance of needing to recognize obstructive sleep apnea earlier and treatment of it with relevance to cardiovascular illness and health. And blood pressure, the odds ratio again, adjusted for age, sex, ethnicity, BMI, neck and waist circumference, smoking, alcohol use. Again, the odds ratio increased for hypertension or blood pressure, and 4-year follow-up still was high. These were individuals who were normotensive at baseline, and as the AHI was greater than 15, in the 4-year follow-up, we found that it was found that the odds increase risk for hypertension proportionally increased when the AHI increased. Again, this was another prospective study done through the sleep health art study, again reflecting the increase in the patient's odds ratio adjusted of as the odds ratio increased for patients who develop hypertension as the AHI increased. Multiple studies have shown the relevance and importance thus of sleep apnea, the need for treatment, and why it should be recognized early, especially with respect to hypertension. I would say, in fact, hypertension was one of the primary medical disorders that threw light into the need for looking into sleep apnea primarily as one of the important aspects to be evaluated, quality sleep to be evaluated in order to have a healthy outcome. And I think over time, the relevance and importance of high blood pressure management has now obviously included part of its protocol, obviously to evaluate all patients for sleep disorder breathing when particularly relevant. Sleep apnea is seen in about 50 to 80% of acute stroke and TIA patients. Was the most common form was obstructive sleep apnea, but we also have central sleep apnea and patterns called Cheyne-Stokes respiration that have been reported. Sometimes there is a question: is it the sleep apnea inducing the cerebrovascular event, or is it following the cerebrovascular event? But it often seems to improve in the subacute phase, not the obstructive kind, but more the central kind, because again, this could be the central apnea, could be more related to the ventilatory disturbance and regulatory drive. Again, the stroke-free survival by AHI quartile was again noted to be another factor in patients with an AHI greater than 20. Consequences of arrhythmias. This is another slide that obviously shows in the presence of an apneic episode, and you have here, for instance, there's no flow. This is the thermistor, this is the PTAP, no flow. And we can also recognize that there's a pause or a slowing of the heart rate, and then there is a pickup with the arousal. So there is a bradycardia and a little speeding of the heart rate. In fact, they do say, though, that the cyclical change of bradycardia and tachycardia is actually a beneficial response in many cases, as opposed to not having any response at all when a person slows down their heart rate. It's also known, though, that patients can, without any identifiable cardiac disease, can actually slow down their heart rate naturally to sleep. It can go as low as 40 to 50 beats per minute as well. So again, there's an increased risk for atrial fibrillation, which is all studied in, this was a paper that came way back in 2007 that talked about obstructive sleep apnea, obesity, and the risk of incident atrial fibrillation. We see a lot of patients in our clinic with either what we call as paroxysmal atrial fibrillation, and then they may end up getting into persistent atrial fibrillation or permanent atrial fibrillation, as they call. And this is, again, a consequence of going back to those slides that we first talked about, the whole concept of how there is a sympathetic activation, as well as the increase in the heart rate with the loss of the parasympathetic drive and the changes in the cardiac rhythm that can occur due to hypoxemia, hypercapnia. So that's why that slide is very relevant in order to identify and understand the variety of medical disorders that can actually occur as sleep apnea is being recognized and the associations with it. Incidence of sudden cardiac death is more likely in those with obstructive sleep apnea, and it actually tends to increase when the AHI indices are much higher, especially when you get in the 40 or above. In fact, there is some theories that obviously suggest that the incidence of cardiac or sudden cardiac death can be more between midnight and 6 o'clock. again, related to various changes in the sleep cycles, REM sleep, etc., cardiac rhythm disturbances, coronary artery vasospasm, etc. So this is an important fact, again, of needing to recognize and treat severe obstructive sleep apnea earlier and quicker. Diabetes, severe obstructive sleep apnea patients with sleepiness are at increased risk for diabetes. Insulin sensitivity seems to improve after CPAP therapy, but the greatest CPAP response and glucose metabolism is in the diabetic patient with lower BMI. So obviously advising them to work on weight loss, which is part of the regimen in management of diabetes, does help. And we're talking more type 2 diabetes because we know a lot of type 1 diabetics may not necessarily have a larger body mass index. Talk about gastroesophageal reflux, microaspiration, and microaspiration obviously either results in laryngeal edema or can cause bronchospasm, and such individuals can have, because of the result of the gastroesophageal reflux, they can have problems related to that, and it can narrow the airway from the acid reflux. The relaxation of the lower esophageal sphincter where it joins the stomach can contribute to the acid reflux because of the negative pressure effect when you are holding, a person is holding their breath against a closed, they're holding the breath, it's a closed airway, making an increased effort. Changes in the pleural pressure, in the intracardiac pressures, all contribute to changes in how the esophageal reflux also occurs. And as a result of the esophageal reflux, there is bronchospasm that ensues from that, etc., and also results in laryngeal edema. So this is a vicious cycle. Consequences of excessive daytime, consequences of sleep apnea can be excessive daytime sleepiness, which in turn results in reduced alertness, vigilance, increased motor vehicle crashes, increased work-related accidents, poor job school performance, difficulty concentrating, reduced productivity, falling asleep, inappropriate social circumstances. Now, we have to remember, so individuals who don't get a good night's sleep, quality sleep, quantity is important as well, may be more predisposed to these scenarios. So diagnosing sleep apnea includes a combination of checking for nocturnal symptoms and or daytime symptoms. So the nocturnal symptoms could include snoring, witnessed apneas, gasping and choking, insomnia, frequent awakenings, nocturia. Now, what we have to remember is these nocturnal symptoms can sometimes be recognized if individual has a bed partner. A lot of times, if an individual is sleeping independently, they are not going to come forward, obviously indicating that they snore or they stop breathing because they're completely clueless and unaware of it. They may indicate, when carefully questioned, that they may gasp for air. Sometimes they may choke, they may cough, but they don't necessarily think too much about it. Insomnia is a fairly broad symptom, as anyone can understand, difficulty getting to sleep and maintaining sleep. But what's interesting is women tend to present more with insomnia than a standard snoring, witnessed apneas, gasping, and choking as a comparative symptom between men and women. So oftentimes, the presentation in women may be more of a, I'm not able to maintain sleep, a chronic insomnia situation, rather than coming in with the above mentioned symptoms of snoring or witnessed apneas. Frequent awakenings, nocturia. Nocturia is increased frequency of urination that they have to wake up to use restroom. There are some theories behind it. As they hold their breath, their heart muscle gets stretched. There is release of a hormone called atrial natriuretic peptide, which in turn induces diuresis. There is also the concept of the negative interpleural pressure, the negative intrathoracic pressure, which in turn reflects on the increase in the bladder pressure and makes a person wake up and breathe. Daytime symptoms can result in somnolence, fatigue, poor concentration. In adults, that is fairly common. Children may present more with attention deficit disorder symptoms. But what we have seen in the daytime symptom categories, where we would have patients that don't really express any daytime somnolence. So sometimes that can be a little misleading, because they may not necessarily notice that they are tired enough to report, and or they may not actually have a degree of hypersomnolence. That's a tricky group. So when the patient comes to the clinic, we do the routine things that need to be done are, blood pressure, oxygen saturation, body weight, body mass index. Neck circumference has been studied that when it increases, neck circumference is measured to be greater than 17 inches in men and 16 inches in women. It's associated with a higher risk for sleep apnea evaluation. Upper airway crowding, you got to look for lateral wall narrowing, a high arch palate, look right down under the roof of their, open their mouth and look right above to see how high the hard palate is. Large tongue, high base, large uvula. Some people have a very thick, long uvula and a high modified Mallampati score, which we will see subsequently. It's often assumed that if you have a larger neck circumference, you should have sleep apnea. And that's a common notion and very true. However, it doesn't, people always wonder whether a muscular neck has a difference between more of a body fat deposition, involved neck, but really the whole point relates to the compression of the airway, which we'll show in a short while. But what is even more interesting is individuals may come in with a relatively normal or narrow neck circumference, but there are other attributes, which are the fact that there is a regression of the jaw, which you can see in this case particularly, that is relative to the lower lip. There is a regression of the jaw, and then there is also a shorter distance between the lower jaw to the hyoid bone, etc. So we can obviously see here the narrowing of the airway, which tends to be more prevalent in individuals larger neck circumference and also narrow airway because of the jaw being regressed, how it can push back. So individuals who come in with a relatively normal neck circumference but have a regressed jaw may actually present with a lot more snoring, and they may not know much more than the fact that they snore. But it's that's important to anatomically evaluate and not just measure the neck circumference alone and go with any some sort of bias. Another thing is to do is called the Mallampati, which is the now called the modified Mallampati classification, where the tongue is kept inside the mouth, it's not protruded in relaxed position. And what they found is there is as the Mallampati score increases from 1, 2, 3, 4, the chances of sleep apnea increase by about 2.5, and in fact may increase by AHI is greater than 5 for each score above the lowest, which is class 1. So that's an important part of the examination. When we have screening tools are available. One is called the stop bang screening tool, which is commonly used, and it's quite a favorite tool to be used as a screening, especially in the perioperative world, post-operative world, etc., as well as in primary care clinics. We'll see the scale score or the stop bangs question is the next slide. But basically, a score greater than 3 has a 90% sensitivity to detect moderate to severe obstructive sleep apnea, and it's got a high positive predictive value. So this is what the stop bang stands for. S is for snoring, T for tired, O for observed. Observations related to stop breathing, choking, gasping, and pressure equates high blood pressure. B is body mass index more than 35, age is more than 50, neck circumference, as we talked about earlier, 17 inches in males, 16 in females, and obviously there's a gender predominance here of males. So more than 3 points indicates a significant risk for OSA, and often leads to needing to be validated through sleep testing, etc. So clinical suspicion and evaluation, we have 2 types of testing. Typically, one can be done at the convenience of the home. That's called a home sleep apnea test, and the other one is a polysomnography. There are many practice guidelines to whom to test and where to test and how to test. These are all well established in papers that are published through the American Academy of Sleep Medicine. Anybody who's interested in it can obviously type in diagnostic testing for adult obstructive sleep apnea, and they should have a whole slew of pages related to the standards of how testing is offered, what are the clinical criteria, etc. Now, the way that this algorithm was implemented was basically to say if the patient has signs and symptoms that indicate an increased risk for moderate to severe apnea, and then it says if they don't, if the patient does not have it, then what do we do? Or if the patient has it, what do we do? So if the patient has the symptoms or the signs, then we have to look for additional decompensatory mechanisms or decompensatory diseases or associated medical conditions. So is there a cardiopulmonary disease? Is there a respiratory muscle weakness? Is there any history of hyperventilation, etc.? And if they do have those kind of scenarios, then you want to do a PSG in an accredited sleep center. Now, you could also, in the first regard of the patient, you could also perform a home sleep study in many instances if they don't have these associated conditions. Once we are treating these individuals, we look for what are the treatment options and follow up after treatment initiation. So there are guidelines and recommendations of when and where to do these tests. As I said, these are all purely based on clinical algorithms depending on associated medical conditions, associated sleep disorder suspicions outside of sleep disorder breathing, in order to say that these individuals can have the testing at home to look for sleep disorder breathing alone, whereas these individuals with additional sleep-related complaints may benefit by testing in the sleep center. Polysomnography is the gold standard for obtaining data. It allows the opportunity for manual PAP titration. A lot of times patients may end up having severe sleep apnea in the earlier part of the test, and therefore there is opportunities for the technologist to be able to wake them up and treat them. It's a multi-channel monitoring, has EEG, EOG, EMG, EKG, oxygen monitoring, as well as video and auditory monitoring. And additional parameters can be measured, such as an end-tidal CO2, where there's a suspicion for hyperventilation. So the uncomplicated patient with a high pretest probability, obviously you don't want to do home sleep test if somebody has significant cardiorespiratory disease, COPD, heart failure, a risk for hypoventilation, neuromuscular disorder, chronic opioid use, somebody who has severe insomnia. They already suffer from insomnia. You take them into the sleep center to try to do a test, assuming that sleep disorder breathing may be contributory to the insomnia. They may actually end up not sleeping at all as well. So sometimes you have to treat this based on clinical judgment. So we go to treatment. What are the treatment objectives? Reduce morbidity and mortality. We talked about how it can affect a person's daytime somnolence, quality of life, and to decrease their cardiovascular, metabolic, and other systemic consequences. So risk counseling is important for motor vehicle crashes, job-related hazards, judgment impairment. Then apnea and comorbidity treatment includes behavioral, medical, surgical. So behavioral may involve, we'll talk about it, but there are things that we need to talk about to any patient who we initiate treatment. So an important aspect is if they are overweight, to lose weight. Exercise is important. There's debate about is exercise okay to do close to bedtime versus earlier on in the evening. There are conflicting reports. Avoiding alcohol and sedative hypnotics is important because that tends to relax your airways. We saw in previous slides how the muscle relaxation can occur. Avoiding sleep deprivation is important because one of the things we should not forget is quantitative sleep deprivation is the single source of sleepiness. Now, avoiding supine sleep position in susceptible patients. Now, this is more after we know for a fact on the sleep study that they have a greater tendency to have events on their back as opposed to their side. So the methods to assist with that. Stopping smoking, because once again, that increases the nasal allergic tendencies, edema, erythema, which in turn increases snoring and apneic tendencies, and maintaining a clear nasal passages, which is important because if you're going to use interfaces involved as in mask therapy with methods such as CPAP or BiPAP, then you need to have a fairly clear nasal passage that is anatomically open enough for you to be able to handle wearing different interfaces. So positive airway pressure therapy, which is CPAP, can be a fixed method as in a fixed pressure setting or an auto titrating setting. We also have bi-level pressure, and that can be used in different scenarios, patient preference, airphagia, they have air swallowing issues with CPAP, pressure intolerance with CPAP, and we have other dental appliances and other treatment options we'll talk about. So the whole concept of positive air pressure therapy is now you got to imagine the first slide that I showed how the airway was on the side view where you could see the collapsibility of the airway. Now, as this airway collapses with the application of CPAP, you're going to see how that opens up that the positive air pressure opens up the airway, which is the plus signs that you see in the area marked in pink and the area previously here, which is a completely closed airway. So that's the whole principle. I tell patients it's a pressurized stent. So we have different approaches. We have CPAP, BiPAP, we have BiPAP, AS3, different terminologies used for different scenarios. The central sleep apnea oftentimes have to be treated either with BiPAP and a backup rate or adaptive servo ventilation. The hyperventilatory group oftentimes require BiPAP or a volume assured pressure support mode. We're going to look at data download information, the number of days used, number of hours used, the current pressure settings, what's actually delivering based on the auto PAP mode or direct pressure, and the calculated AHI, which is an average indices of how often you hold your breath or shallow breathe and the amount of mask leak. Those are all important because a lot of times secondary effects, patients' intolerance from mask leaks can prevent them from using the CPAP. High mask leaks promote dryness of the mouth. AHIs may be much more elevated because of poor fit. So lack of usage, all these things have to be taken into account. So some normal downloads, if we look at the green bars representing an average good use, which is more than 4 hours. And, I've not zoomed into these slides, but essentially these are things that we look at the nightly data, the settings, the efficacy, etc., aiming to see that the AHI numbers are under 5. So adherence to therapy in the first 7 weeks, one of the greatest predictors of long-term adherence. Subjectively report about 75% of use and objectively measured is 70 to 71%. So compliance with asthma medication is only 30% when you see this. So again, the problems with compliance is universal. It's not specific only to sleep apnea and or CPAP therapy. Compliance to medications and other disorders is also a factor that we have seen. So we find that actually better education and learning to intervene earlier on improves adherence to PAP therapy. A lot of reasons why people don't wear the CPAP, which I've seen in the clinics, is the lack of understanding the sleep study. If you get a sleep study result or call about your sleep study and you're told you have X number of events, well, sometimes it obviously surprises them, sometimes it baffles them, sometimes it makes them very nervous. They want to get started in treatment, but as they go through the treatment, learning to get used to this machine, the mask, etc., they're having problems with it. They don't know that they're perceiving benefit. And as I mentioned earlier on, some people may not necessarily notice any impairment in daytime functioning, so they don't know why am I asked to do this. It may not be what I really like to do. So lack of perceived benefit, lack of excessive daytime sleepiness. Sometimes people are the habit of taking other medications, even substances, use of alcohol, etc. So they don't necessarily remember to put their CPAP on and what if. Nasal passage obstruction creates difficulties in trying to get used to different styles of mask. A person may want to use a mask that just goes on the nose, stays under the nose, but their nasal passages may promote more of a mouth breathing effect. So they'll have to go to a larger mask, a full face mask, and that may not be their cup of tea. So there could be problems with the adherence, side effects from rashes that can come from the headgear, from the cushions in the mask, etc., that they don't like. Obviously, claustrophobia. And sometimes this whole concept of going back to a nightly use creates scenarios of post-traumatic stress that they may have experienced in life, and they can be important factors. So strategies to improve adherence, patient education, frequent and early follow-up. So that's why I think it's also helpful with Medicare guidelines requiring for patients to be seen 31 to 90 days. It's helpful to be at least be able to bring them in within that time frame. Earlier return to the clinic after starting therapy actually would improve their adherence and compliance, but sometimes you may not have time in the clinics to get them that quickly in. But that's why it's important to address the problems early, address the massive issues, address pressure issues, etc. Desensitization therapy sometimes requires for them to be told, okay, you're awake, but wear your CPAP, get used to it, adjust your headgear, see how you do with it. Can you tolerate the pressure? Lie down in your bed, do different things so that you're more adapted to using the therapy before you actually go to put it on at night. Equipment optimization is another thing apart from behavioral modification, where you have to ensure the optimal interface, fit, absence of leak. Each mask has its own leak factor too, so you got to pay attention to that and see if there's going to be a degree of intentional leak and there's going to be unintentional leak, and you want to make sure that the leak factor doesn't exceed too much, which it does, as I said, consequently leads to dryness of mouth and the whole 9 yards and difficulty. Comfort settings are important. Humidification, ramp, expiratory pressure relief is very important. They call it flex mode in some machines, EPR in some machines, but the whole concept is to provide the relief in the exhalation force so that they can smoothly take their next inhale breath. So they found that as CPAP is being used, the quality of life, Epworth Sleepiness Scale scores, which is the ESS, and the multiple sleep latency test was used to measure that. What they found interesting is people would say that they would go to sleep very quickly when they had sleep apnea, not recognizing that, may actually have a little bit of a delay in the sleep onset latency after they started on CPAP, and may have a normal sleep latency, which is 10 to 20 minutes, which is quite surprising to them because they are the ones who they fall asleep as soon as their head hits the pillow. But they found that with concomitant use of CPAP, that they are able to remain more awake and they're able to get to sleep in a more natural rhythm. So that is an interesting finding. They also found the effects of blood pressure, much better results with blood pressure, reduction in blood pressure overall in patients treated for obstructive sleep apnea. A couple of slides that relate to the same article. Pulmonary hypertension, as we talked about in the earlier slide, the first group of slide, the first slide or the first few slides, as we showed you the consequences of sleep apnea, where there is an increased strain on the right ventricle, increased pressure. There are some concepts that if an estimated, this is not the correct measurement of the right side of pressure, usually a cardiac cath does that, but an estimated right ventricular systolic pressure using an ultrasound guided, which is the echo device, will help us to estimate the pressure. It was normally under 45. That's considered, the normal range is 25 to 30, but if it's between 30 to 45, basically can be correlated to underlying obstructive sleep apnea. If the pressure is estimated to be more than 45 or more, sometimes you may not blame it on sleep apnea alone. It may be a concomitant issue, but you may have to look for other reasons for that elevated pressure. There were benefits and improvement in the pulmonary pressures or right-sided pressures with CPAP therapy as opposed to a fixed therapy pressure versus a random CPAP pressure. CPAP reduces the vascular myocardial sympathetic activity, as we saw on the previous slides, the mechanism of how it could do it, improves what now they call as heart function with heart failure with preserved ejection fraction. That's what they call as diastolic dysfunction, FPEF. And therefore, it does improve that, prevents the chance for negative pressure pulmonary edema to occur. It's associated with reduced readmission rate, health cost, mortality. And this is an important concept that CMS and others focus on, the readmission rates for patients who have sleep apnea and not yet treated, and how they go about doing that. So bilevel is the concept introduced in patients. Normally, when there are issues developing, when they have intolerance to CPAP, they have an oxygen level which is still low despite adequate control of the respiratory events of CPAP, and or sometimes when you do blood gases, They may come in with a persistent headache, and you rule out all other reasons for headache, and you have blood gas, elevated carbon dioxide. So even though the CPAP may be working, they do not have the volume of air, the pressure support that they need to expand the lungs in order to blow out the CO2 levels. So hyperventilation syndromes, complex central sleep apnea, or other indications where you can use bi-level as well. So there are two independent pressures. One is called the IPAP, the other is called the EPAP, to maintain the airway stability, and support ventilation requirements while the patient sleeps. The time that it takes for the BiPAP to change from the EPAP to the IPAP, it can be adjusted for patient comfort and the volume of air that they get with each breath. Average volume of air that we get with the breath is estimated to be about 500 cc. So spontaneous mode is where the person's normal breathing takes into account the pressure that you set and goes in synchrony with that. So the demand with each breath, the pressure that is set is going to give that volume of air. It's used often in patients with obese hyperventilation, neuromuscular weakness disorders, restrictive thoracic disorders, obstructive lung disease. Time backup rate is used for patients who have an inconsistent respiratory pattern, especially more the neuromuscular disorder patients, where we can rely on them to make that effort to get the breath correctly on a synchronized basis. So we do have a time backup rate, which will provide the mandatory breath based on how you set it, every 5 seconds, every 6 seconds, every 10 seconds, however you set it. So they can spontaneously initiate the breaths, or they tolerate the time backup breaths from the device. That's the purpose in the time backup or ST mode. We usually use the EPAP to control obstructive apnea and the IPAP to maintain a pressure support, that is a maintenance of 4 to 8 centimeter difference, to control the hypopneas and the snoring. And for central apneas, if we have to use the BiPAP because we may not be able to go to ASV for specific reasons, they have an ejection fraction which is lower than 45%, we could still attempt to use BiPAP and attempt a backup rate in those cases to try to address the central sleep apnea pattern. So it's appropriate to titrate it bi-level to pressures to control apnea, hypopnea, and snoring. And if hypoxemia exists, then sometimes you have to augment the tidal volume by increasing the IPAP in increments in an attempt to improve the oxygen saturation. And sometimes you may end up needing to use oxygen with this, because not all hypoxemia is obstructive hyperventilation. So these are methods to measure the CO2 levels. You can use either a transcutaneous monitor or an end-tidal CO2. An end-tidal CO2, usually a transcutaneous is used after you start them on therapy with BiPAP. An end-tidal is often more favored in the diagnostic portion of a study. And we want to use the lowest possible EPAP. You may have people combining with combined disorders, COPD and obstructive sleep apnea. They don't tolerate a very high EPAP. They have to exhale out for a long time, and you don't want to push the EPAP too hard against that. So it is important to keep the EPAP just enough to overcome the resistance in the airway, just enough to eliminate the apneas, and then keep a wider pressure support. So these are again some guidelines as to where your cutoff points would be. Now we talk about a mandibular repositioning device. Again, the same concept. Everything draws back to that fundamental slide that we saw about how the airway collapses, and with the mandibular repositioning device, how it is pulled forward and the airway is kept open. So there are, again, clinical practice guidelines for treatment of obstructive sleep apnea and snoring with oral appliance therapy. Anybody interested in it could take a look at it. So usually it's much better to use a mandibular or referral for a mandibular reposition device yields better outcomes, I should say, when the person's initial sleep study has a lower AHI, younger age, lower BMI, and if they are more supine dependent obstructive sleep apnea, and repositioning the jaw seems to help. Certain cephalometric variables, shorter saw palate, decreased distance between the mandibular plate and the hyoid bone helps that movement of the jaw forward much better, and those who have a lower nasal resistance. Where you don't want to use is where they don't have insufficient number of teeth to hold the device. They've got to be at least 8 teeth, the upper and 8 teeth in the lower of their own to anchor the device. Untreated periodontal disease, tooth mobility, and not good areas to situations to go for a mandibular reposition device. Likewise with active TMJ disorder, or when there is limited maximum protrusive distance or significant grinding. Again, the mechanics is to push the airway forward as depicted on this diagram in the blue arrow. So positional therapy. What is positional therapy? It's an effective secondary therapy, supplement to primary therapies for those who have a lower AHI in the non-supine versus that in the supine position. Most likely, individuals who are to have supine dependent sleep apnea are younger individuals who are less obese and less severe obstructive sleep apnea. So it's different from other types of sleep apnea position in that the vast majority of symptoms occur when you sleep on your back. So what treatment will position you to be at your best and to reduce your symptoms? There is the standard, what we call as the tennis ball technique. You can have a bunch of tennis balls stitched onto the back of t-shirt, and it helps you to avoid, getting on your back, but you got to do this on a nightly basis. Surgical therapy, there are many surgeries that are done. Obviously, you want to crack the nasal passages, turbine reduction, polypectomy, septoplasty. Many other surgeries have been tried. And of course, to sum up, we have the maxillomandibular advancement. You have the UPPs, which is the shaving off the uvular palate, straightening out the palate. I don't think it's much favored anymore. We do have maxillomandibular advancement that some individuals may favor, especially if they have a regressed jaw, to move the jaw forward. Same concept, moving it should be allowing the similar concept of a stent pressure from a CPAP working and providing the air by moving the jaw forward. Now you don't need that pressurized stent, and thereby the airway clears. Again, it's a fairly gruesome surgery, but there are brave hearts to want to do that. We got a hypoglossal nerve stimulator. I believe there's a separate lecture, so it'll be touched upon by the expert in that field. And then you have tracheostomy. Obviously, is used as a measure in extreme cases only. So these are just examples of what they mean, the UPP, the shaving off the square. I've not seen a whole lot of improvement in patients who have UPPs. Their snoring may drop a little bit, comes back, and their apneic tendencies still remain. There are office procedures sometimes used by ENT to help with snoring, laser-assisted uvulo-palatopharyngoplasty. And we talk about the mandibular mandibular and maxillary advancement, which is basically moving the jaw forward, thereby creating more room in the back of the throat. And again, there are practice parameters for those who are interested. These slide sets are more to offer more detailed review for those who are interested. As I talked about, there's upper airway stimulation, which is in my book, I call the new kid in the block, which helps provide a treatment option for those with moderate to severe obstructive sleep apnea, having a lot of difficulties with CPAP. Essentially, it just has, you do have a surgical procedure required by ENT, a pre-surgical evaluation, and at the end of the day, a person is offered a remote activating the device and sleeping. And as I said, we'll learn more from that. We do have patients sometimes offered, those who have mild to moderate obstructive sleep apnea, who don't tolerate a dental device because they have TMJ. They can't handle CPAP. They're not the typical individuals who have positional therapy benefit because they don't have much by way of events on their back. In fact, they're side sleepers and still have mild to moderate obstructive sleep apnea. There's not much room to lose weight. There's not much room to modify social habits. So where there are methods, there are nasal strips. The whole idea is to allow an inhalation process. You inhale all the air, so when you breathe out, it actually forms the increased pressure on the exhalation raises when you inhale, and then when you exhale, the strips manage to block that exhalation force, thereby increasing the pressure, creating an EPAP force, which in turn does help to keep your airway open. So we have the proven nasal strips. Now, of late, I've been hearing that they are going to discontinue this. True or not, I do not know, but we have a few patients who use this, who have struggled to use CPAP, and the individuals that I have used are actually ones who have come in with CPAP difficulty, not because they didn't want to use it, not because they didn't like to use it, but actually had glaucoma or intraocular pressure that started to increase after going on CPAP. So they decided to go to alternate methods like this. Tried dental appliance, didn't work, so finally decided to go with this. I believe there are special cannulas that can be inserted at the end of the device to measure their flow if you want to take them to the sleep lab and see if they are breathing okay, as a measure of seeing their improvement. And of course, you have the bongo device, which are nasal dilators, which seem to go more firmly inside the nose. And again, the same concept of inhalation and holding the airway pressure when you exhale. So as we're coming to the end of this, obstructive sleep apnea is common. It impacts long-term health. It's easily recognizable. It's treatable. I just want to talk very briefly about a concept called treatment emergent central sleep apnea. We run across this a lot. I'm not going to spend a whole lot of time with that, but essentially would like to say that obstructive sleep apnea that tends to convert to central apnea with CPAP application. It typically emerges during a titration and not obvious during diagnostic polysomnograms. And we find that there's an estimated prevalence of 7 to 15% of the sleep disorder breathing populations. Examples of after CPAP is initiated and obstructive apneas are cleared, then you have central apneas. There's no flow, there's no effort, as seen in the highlighted areas. So there's a change in the respiratory rate that changes the CO2 levels. The brain reads this change in CO2 as hyperventilation, and it represents the central apneas during the CPAP. And that's why it used to be called as complex sleep apnea, but then they brought the terminology change to treatment emergent central sleep due to a combination of upper airway resistance and abnormalities 1 and 2, often a temporary abnormality of ventilatory control, we get these complex apnea, which is the central apnea emerge. And then as the respiratory rate regulates itself, we find that there is a return to normal breathing. Oftentimes it's felt to be probably related to excess pressure. The most common treatment is to try to reduce the CPAP pressure. It's not uncommon to see some central apnea continue in patients with CPAP for a while, and not everybody requires to be taken to the sleep center for more advanced therapies such as adaptive ventilation, but that's something to keep in back of mind. And an extra 1 hour and 42 minutes of sleep really makes a big difference. Of course, getting better sleep makes a huge difference in the quality of life, concentration improvement, and a variety of improvements that we've talked about that go in hand in glove in management of sleep apnea. So one thing to remember always is when an individual presents with daytime sleepiness, one should not forget the concept. Are you quantitatively sleep deprived? That's the first question to check and educate. Is there a quality of sleep issue, such as sleep apnea? We also want to look at any medications that may be introduced that may contribute to daytime sleepiness, as well as any medical conditions that may have come along that may be contributing to daytime sleepiness. Thanks for inviting me for this, and hope this information shared will be of benefit. Thank you.
Thank you for joining us. You're now in the Q&A portion of our first session. I'd like to welcome Dr. Devanathan to the Q&A session. Thanks so much for joining us, and thanks for your enriching lecture. It's a great way to kick off the event. It's good to see you today.
Josh.
We do have a few questions that have been submitted, so I'll jump right in, and feel free to respond as you can. Thanks so much. First question comes to us. Any current protocols or best practices on titrating hypoventilation patients using end-tidal CO2?
I guess the end-tidal CO2s largely are used in the, if I may say, more in the pediatric world, where there's part of the components of using the CO2 levels to identify the hyperventilatory status. We do use that in the adult PSG portion, the diagnostic portion of the study, because once you add the titration part, the CPAP, the BiPAP, the end-tidal CO2 sort of lose their value. So that's why we use transcutaneous CO2s on those portions of the test to titrate. I guess the goal is to kind of identify where you can keep a certain CO2 level that you would prefer to have, which would be commensurate with the patient's clinical status. So individuals with underlying obesity, hyperventilation, restrictive thoracic diseases, COPD, etc. If we had to categorize them in the world of hypoventilation, when we have to use non-invasive ventilation, we use the 45 millimeters of mercury for the non-invasive ventilatory folks who have neither neuromuscular disease, hyperventilator status. So we could aim for that if you were to think about something in that direction. And if you think about the COPD world, you could aim for a CO2 level under 52. I don't think that this is a set strict guideline or protocol, but this is something that you can aim for, because those are some of the transition points to go to non-invasive ventilation where there's more volume assured pressure support modes used. So I think that will be there. There are some current practice guidelines that talk about hyperventilation and adjustment of volume assured pressure support. These are well published in the Journal of Clinical Sleep Medicine. So anybody who's interested can type in again about hyperventilation and titration guidelines, and they are freely available. But these are some general guidelines we aim for from a clinical perspective to try to keep those CO2 levels commensurate with their underlying clinical condition.
Great. Thanks, Dr. Devanathan. Another question just came in. We've heard a lot of complaints about sinus issues with CPAP use. Do you have any recommendations on how to improve that?
Excellent question. Now, we know that actually the CPAP by itself can induce a rhinitis. There's actually an encounter diagnosis called CPAP-induced rhinitis, and that's because of the material in the mask by itself, especially nasal pillows, may contribute to some further irritation. I think first and foremost, we need a good clinical examination to see how the nasal passages look like. A lot of times the irritation may come from things like examples, sleeping on feather pillows. They are irritants. Having pets that shed at home maybe needing to clean air ducts in the house if they're not been cleaned, avoidance of things like smoking, etc., which tend to irritate the nasal passages. So those are some simple things to start with. Of course, people also have extensive allergies. They will need to be tested for that. So these kind of initial factors may further aggravate the rhinitis when CPAP is induced just from the material. So I think treatment of those factors is important, and some individuals may need a trial of nasal steroids. Some individuals may need surgical correction of the nasal passages if deemed appropriate, adequate good sleep hygiene measures such as avoidance of smoking completely and especially close to bedtime within 6 hours, and in the long run may need treatment for allergic rhinitis through either intranasal steroids, sometimes medications. I wouldn't really spell out the names of medications because I don't want people trying to say this is what we need to use, but there are medications that can be used for allergy reduction, etc., can be applied. Now, I've also seen, due to the nature of the mask material, sometimes it may be a good idea to go to what we call as the cloth masks. And again, this is not a promotional event of any particular cloth mask or anything, but there are some cloth masks available in the market that have been used in people who have extensive allergies, who have difficulties tolerating the CPAP from rhinitis, that have actually been very favorably used by patients when you go from the material that is provided in the regular mask to a cloth mask. And there are cloth nasal masks and cloth even full face masks. So I think that would be helpful to kind of think of. But those are some of the preliminary measures that we take when we have difficulties with rhinitis and obviously trying to figure out where we are. Now, if the control of, if the management of rhinitis becomes very difficult and the patient obviously cannot handle a CPAP, then you may have to look at other methods of therapy. But then again, one of the important things in the whole anatomy of the areas we talk about starts from the tip of the nose to up to the vocal cord. So treating that nasal passage is going to be important because you may not be able to easily jump from a CPAP therapy to a dental appliance, assuming it'll be fine, unfortunately, because the nasal passages being very narrow and congested may not be conducive to just a response to a dental appliance. So that's something to be aware of.
Great. Yeah, that's helpful. Definitely a relevant time to talk about sinus challenges and other ways to overcome therapy. So thanks for those tips. Another question that came in as it relates to, you talk a lot about the Mallampati score and evaluating patients through that regard. Wondering if there's any correlation to that score and a higher pressure requirement that the patient might need.
Actually, an extremely interesting question. There are mathematical derivations about probably assessing the airway and arriving at pressures. I think they're complex math figures, of course. Personally, if I may say, while there is an increased suspicion for sleep disorder breathing that we can come up in the clinic based on their Mallampati, I don't think there has been a direct correlation in how much pressure they need, because unfortunately we have seen quite a little bit of a contrast in two things. One is the severity of sleep apnea and the expression of daytime sleepiness. That's one group. And the severity of sleep apnea and the amount of pressure that the person needs. So the Mallampati may be a helpful way to assess the preclinical test probability to say whether they need to be evaluated for sleep disorder breathing, but not oftentimes has been directly correlated to an exact pressure, as best as I know. There may be some articles out there that could have looked more deeper into it. But as I said, there are some papers that talk about, where you could probably through mathematical measurements assess and probably feel that there is a certain amount of pressure that you can apply, but obviously they are not the algorithms that we use in the clinic, because most times we either apply an auto PAP mode or we take them to the sleep center and try to figure out the best pressure. That's a really great question.
Great. Thanks so much, Dr. Devanathan. One more question, and we've got about a minute left to answer. Do therapies such as Provent or Bongo have defined parameters for the best population for success? And is that therapy typically tried before or after PAP therapy?
Very good question. I think the papers that have come out about these nasal strips and the nasal dilators, because the Provent is more like a nasal strip and the Bongo is a nasal dilator, are more recent. I think the bongo was something that was actually sort of tested in a limited group through the Mayo Clinic and presented as an option for mild to moderate sleep apnea patients. And actually, I think they did find some good results utilizing this. I guess the first and foremost thing is to kind of, again, clinical examination, the nasal passages to see what it is. Second thing is to see what their end results of the sleep study are. Third is standard application of methods that we go in, either a trial of CPAP or a dental appliance, maybe things that we think of. Partly because I think some of it, if the patient wants an insurance to cover for it, there may be a rationale to say that we tried the standard techniques and it's not working, and therefore we're going to, these are not unconventional, but they are not the first that we approach usually. So I guess part of it will be dependent on insurance-driven protocols as to try the standard method. And there have been good results expressed in limited literature about the nasal strips and the ProVen nasal strips as well as the bongo. As I mentioned, there are special cannulas that you can insert along with the nasal strips to identify it. But I think some of the problems that I am hearing is that there may be a discontinuation of the product. If that's true, that would be a change. But
Well,
it is.
Dr. Devanathan,
It is a useful option to think of when the standard traditional approaches, which we normally take, don't seem to work, and or if there's something that you can present to the insurance ahead of time to say this is what I'd like to try based on patient preference.
Well, thanks so much, Dr. Devanathan. I know that was, we gave you a tight window to answer a really robust question. Can't thank you enough for participating in today's event, and we look forward to working with you again soon. And for everybody else, please feel free to log into the next session now. Thank you.
Thank you so much, Josh. Have a good day.
Take care. Thanks.